Good day, everyone. I'm sure you've learned a lot from the previous lectures. And so at this point in time, we are now going to set up our smoking cessation clinic. Just like any program, we should decide the structure of a clinic. We have to decide whether we are doing it in the hospital or a hospital-based outpatient clinic or a community-based clinic, and decide the organizational structure. So this is an example of the organizational structure at the Lung Center of the Philippines. So the head of the program is the program director and reports to the outpatient manager. So under the program director is the following staff: the advisor, the coordinator. If you notice, it will divide into a smoking cessation clinic head and a quit line services head, because we have a face-to-face counseling clinic and a quit line service clinic. But under that, we have also the counselors, and these counselors can provide services to both the smoking cessation clinic via face-to-face and the quit line services. After we have decided upon our organizational chart, we have to create now the administrative system and policies, which will guide in every process or workflow. We determine the procedural policies for the staff will provide smoking cessation intervention via face-to-face or via telephone counseling. We identify the models for smoking cessation intervention in health plans and health insurance, and prescribe reimbursement policies for clinicians for delivering smoking cessation treatment, and include cessation treatment as part of their duties. So this is the process of creating our administrative system. We have to define the function of the smoking cessation clinic. So what do we expect from the smoking cessation clinic? What do we want to achieve? What are our goals? What are our outcomes? And after that, we have to define the duties and responsibilities of the staff. So what do we expect our smoking cessation program director to do? What do we expect from our smoking cessation specialist and administrative assistant? Of course, we have to have a budget. So we have to have an idea of how much we need to keep the program going, and communicate, of course, with the management so that we can get the budget that we need. We also should have the reports ready for our management to evaluate, and of course, if we can determine if our program is doing well or not. So we have to determine our quit rate, the number of consults, inbound and outbound calls. We have to provide data on our advocacy activities and outreach programs, and take note of the workshops and seminars conducted and attended by the members. These are an example of the forms also that we could use. We have forms for information of the patient, referral form, progress report form, and referral to the hotline. And of course, we have to have a forms from the outpatient department in terms of tracking the number of patients at the scene in a day. And lastly, the files management. It is important that we systematically file our data so that we could track also the data of our patients and the programs that we have done. And of course, it should follow the Data Privacy Act. We have to adopt a program wherein it is evidence-based and integrate it in the standard of care for our patients. The models of counseling that you can do is either motivational interviewing or cognitive behavior therapy. For the modes, it may be done via face-to-face, telephone or quit line counseling, or web-based or mHealth. We have to evaluate our success and determine the quit rate, the quit attempt, and the stages of change. We have to identify, of course, the target of our program or the target population. Are we targeting only the hospitalized patients in the hospital, the outpatients, or the general public, or those referred by physicians, or walk-in patients or self-referred? The program models are usually the 5 A's that was, I'm sure, extensively discussed in the previous lectures. So it is ask, advise, assess, assist, and the range. We also do the 5 R's, which is relevance, risk, reward, roadblocks, and repetition in helping our patients establish their motivations and being able to eventually decide to quit. A dedicated staff should be provided, and it may include a physician who will prescribe the pharmacologic therapy or treatment, may include the nutritionist to advise our patients on how to eat properly, and the physical therapist to conduct an exercise program, and the smoking cessation counselors or quit coaches who will provide the training for those who will want to learn or seminars who will want to learn eventually on smoking cessation, and of course to provide the intervention for those who actually want to quit. We should provide our staff adequate training in brief tobacco intervention and motivational interviewing. So what are the functions of a tobacco cessation counselor? A tobacco cessation counselor is expected to provide counseling, health education, and relevant advice to the smoker, establish rapport with the smoker, assess the smoking cessation history or the smoking quit attempts or quit rate, nicotine dependence, and readiness to quit, develop a clinical impression about the patient, prepare a quit plan, maintain clear and accurate records, and arrange follow-up. So the modes, it could be again face-to-face, telephone quit line, or web-based mobile applications. For follow-up, we could follow up the patient 1 week after the quit date was actually set, and a second follow-up contact is recommended within the first month. Further follow-up visits should be scheduled as needed, and during a follow-up visit, success should be congratulated. So this is a sample of a schedule of follow-ups that we could actually do. So we can call or talk to the patient 1 day before the quit day so that we could at least coach that person or inspire or encourage that person to really push through with the quit day. On the quit day, so at least we can again give some confidence to the person, help them in terms of giving them advice on how to handle just in case cravings or withdrawal symptoms. 24 hours from the quit day to see if there are other problems that was encountered prior to quitting or after quitting. And then of course, weekly follow-up for a month, and then monthly follow-up for 6 months. So outcomes can be measured via computing for the quit rate, relapse rate, and of course, with regard to the changes of stage or stage of change, we could help our patients from, if for example, he is from the pre-contemplation stage to the contemplation stage. If there is a change in that stage, then we could consider that as a success, or from pre-contemplation to preparation, again, if there is a progress, we could still consider that as an outcome or a positive outcome. So in summary, we should determine the site, the equipment, and the staff, create administrative system and policies, identify the processes and the procedures like recruitment, counseling, monitoring, and follow-up. We could also determine the outcomes such as quit rate, quit attempts, smoking reduction, and stages of change. And we could also do biochemical validated outcomes like measuring urine or saliva creatinine or smoke analyzers. So thank you very much and stay safe.